How are you all? We will start our next sessions about the abdominal intervention radiology. يعني استاذن حضراتكم بقى الناس تبدا تخش عشان نقفل الابواب بعد اذن حضراتكم.
عايزين نقفل نور القاعه.
طبعا احب ارحب بالساده الشير بيرسونز استاذ دكتور محمد الورائي، استاذ دكتور ايهاب سعد، ومعانا استاذ دكتور محمد فوزي. هنبدا اول سيشنز. معانا دكتور محمد هي introduce our first speaker.
Thank you, Professor Wissam. I would like to introduce Professor Afshin Gangi. Professor Afshin, he couldn't be with us, but hoping next year he will be able to make it live. He will give the presentation online. He's a professor in interventional radiology, University of Strasbourg, and head of CERSE. He'll give us a talk on cryoablation for renal masses. Thank you, Professor Afshin. You're with us?
Thank you so much. Thank you so much for the invitation. I will really miss Egypt. I would love to be there with you. I'm really sorry because I'm between two travel, London and then another one. I cannot be with you, but promised I will be next year with you and visit Egypt again, my favorite country, and with your history. Thank you so much. My first talk will be about kidney cancer. And as you know, the point is we as an interventional radiologist, we should be a lot more implicated in the clinic. That's essential. That's a clear cell, that's a papillary, that's a chromophore, because each of them can be another family disease. Chromophore is a very specific disease. All of them are very different. That means when you are considering a thermal ablation with your colleague, urologist, oncologist, you should know the histology, the staging, and the grading. The grading is essential again, because grade 1 and grade 4 and eventually the sarcomatoid are not the same at all. Means the margin should not be the same. Patient condition can support the treatment. Renal function, essential, before and after. Then we are finally talking about the size of the need to talk first. Vascularization of the tumor, hypervascular tumor. Majority are, but some of them are not, but hypervascularization is an essential point to be considered. Location of the tumor, central, peripheral, upper pole, lower pole, contact with the other organs. Essential again. Central tumor are the most difficult one to treat. As I said before, the junction is essential. Junction of the ureter, how you are doing. Then you have the TNN, you are sure there is no metastasis. All this considered together with the staging, we should know this before deciding to do the percutaneous treatment. Grading, as I said before, essential to talk about grading. That's because when I'm usually sending the grade 4 for a larger surgery, or sarcomatoid and vascular systematically for surgery, because they need really to remove a very large sarcomatoid. Means grade 1, 2, 3 are good for us, 4 are becoming very tricky, or we need to do a large margin. Means, if there is no confrontation surgery, those ones are better for the large resection and surgery. That's essential. And the case of the ablation, as you have seen, for us, when the patients are, every patient, particularly when there is difficulty surgery, but again, for T1A, it can do them quite old, that's true. Technically, we are good, but however, today, the Urologists Association are including us just as the native when there is problem. That means if the surgery is possible, we couldn't get to this patient. That's why we need more data to prove that our technique is as good as partial nephrectomy, minimum in T1A. That's very important. For us, the best indication, as you have seen today, are comorbidity, single treatment, best indication for us is already nephrectomy, RCC, multiple family disease, all VHL patients are the best for us because we can go and do small ablation anytime we want. Ablation itself, I really tell you, you need a cross-sectional imaging. Means CT scan is the minimum because the eyeball, especially with cryo, you cannot see the ultrasound. We do them in both MR or CT guidance. I think MR is difficult to get access, but it's beautiful image. I will show you how beautiful it is. But again, you need to see the eyeball. If you cannot see the eyeball, you cannot do the right job. You can eventually put the probe on the ultrasound, even though the probe should be quite nicely parallel, you can cover the tumor. If not, you need to see the eyes with CT scan or the MR. As you can see, ultrasound, you have a blind view, just the superficial part of the eyes and not see the deep part. This could be a trouble in some situation. Which technique to choose? I will tell all who are working. I give a point personally, that's my opinion, microwave for the kidney, because I think it's too powerful. I love RFA for peripheral vision. Why is my preferred technique? Because I can see the eyes, as I said, and the scarring is better and I'm not damaging the central cavity. It means the excretory system is not damaged to it. However, if you freeze the junction, cryo can damage because having a stenosis, which happens secondary to cryo. However, when you freeze the part of the cavity, you will eventually have a small hematuria, but it's very well tolerated compared to RFA, which can shrink the cavity because of the electrical conductivity. That's important. As I said, if you have cryo, I will put it first line for kidney because you see and you can exactly shape your eyes and tailor the eyes to your tumor size. The typical phase is 10 minutes, 10 minutes, 10 minutes is the conventional. 10 minutes eyes, 10 minutes setting down, 10 minutes freezing again to consolidate the apoptosis in the periphery of the tumor. It's long. I agree. It's a long process. You can do a siesta in between sometimes, but you have to follow up the eyes and it costs more than the RFA. Sure, that's a key point of cost with cryoablation and to cover some side of the eyes in there. Another very important point of the eyes probe is you have to put them more in the periphery of the tumor. I'm always saying don't go in the center because the center accuracy is very rare. The tumor is happening all around. That's why I put the probe maximum at 5 to 10 millimeters to the border. I even love to go on the border directly. So I take the tumor in the bracket. So I'm safe. I'm safe to have a large ablation. And you will see the vascular part of the tumor is always resistant to the eyes. Means the eyes grow in the periphery, and the central part which is hot, it will straight, so that the part is irregular. As you can see, in this example, the hot part of the tumor is the red part, which means this part resists to the eyes, like the way you look at it, all other techniques. Means that's why our probe should be very, very peripheral to the hot part of the tumor. You see, that's the hot part of the tumor. You can see them all the time. This is something to consider. Means your probe should really cross the peripheral part of the tumor to be able to do it. Worst one, the fully central one, are getting so much recurrences because the kidney is so hot and the vascularization is so fast. Those cases now, I will show you an example. We are going to do a vascular occlusion during the intervention. We'll see this later. Look at the eyes for shape in the heart. Everything is round outside, everything is flat inside because of the cold skin effect. Examples now, how to use cryo. You see nice tumor in the periphery of the kidney. Difficult part is where? The central part. Don't forget it. This is the hot part of the tumor. This is where you will have recurrences. That will be difficult. I mean, in this case, if I go straight perpendicular to the cavity, the strong part of the cryo are in the side of the needle. So the weak part is on the tip. So I don't put the tip toward the part. I need to come and put my powerful side facing the hot part. That's why you need to come back. You see the picture that the side of the needle, which is powerful, is facing the hot part. That's important. That's a key point of success for cryoablation. Examples, you see another case, when you have the cancer, the three probes are positioned very centrally, one in the periphery, and as you can see, again, convex part of the eye outside, flat part inside. That's very typical of everything. That's why when you put more probes inside, you can obtain better ablation in those cases because you have a nice eyes wall inside. It should be covering the tumor. And if it's an easier form, 1 or 2, you need 5 millimeters margin. If it is your 3, eventually 4, you need more than 5 millimeters, they have 1 centimeter margin to be good. Size, 1 to 3, usually 3 probes. You see what I mean? Then you have more that you have four probes. Again, in the size, you see every 1.5 centimeters you put a probe. And as you can see on the diagram here, the probes are more in the periphery of the tumor, not in the center. There is no need to do it. You can see the eyeball of the tumor is there. Eyeball, 4 probes, every 1.5, and more in the periphery of the tumor than central. And here you can see if you are in the central part of the tumor, sure, you put in the periphery and one in the center to cool down. If you don't have vascular occlusion, that's typical case. You see the central part of the tumor, hot part, huge, but that will recur if you cannot have your 5 millimeter margin. Don't be afraid of the cavity as I said in the eyes. That will freeze, but it will not damage the cavity. That means you can do it. And again, have you seen where is the tumor? Again, surrounding tissue, bubble. Be careful that the ice is not getting and freezing the duodenum. In this case, hydrodissection is essential. Plan it from the beginning. That's what we have done. You see, I saw 5 probes, and 1 in the center. 1, 2, 3, 4, 5, and a 6th one in the middle. Every 1.5 centimeters, and the hydrodissection needle is done to dissect and push the duodenum. That should be essential for us. Another central tumor, you see, those cases are the difficult cases. That's what you get in those patients. Put more probes. And in this case, as you see, the colon is in front. A needle for hydrodissection is systematically done. Push all these organs away. If one hydrodissection is not enough, put another one. Before you are not safe, you are not making the ablation. That's essential. So in this image you see on the MR, the whole kidney is surrounded by fluid. So I'm safe, I have nothing in my body, I can't please push. Now I'm going to example. Very quickly. Biopsy proven RCC is 70 years old, easy case. In this case, you know what I mean? RF will work perfectly. Will work perfectly without the needs. A lot cheaper. So in this case, I will prefer if I can, I will do it. RF. That's the case. You see, one probe. Again, the probe is put on the border of the tumor internal probe. I'm not going in the mid, I'm going more internal to have the margin inside. And look at the control, nice control. That's the second case. This is again in 74 years, peripheral tumor. What can I do? Any protection? Eventually I will protect the chest wall because I don't want to burn the muscles and the rib if I can avoid it. As you can see here, fluid injection in the periphery with some local anesthetic so you get the margin between the ribs and the kidney. Why damaging something you can avoid? You see what I mean? Even if it's not catastrophic, it will be painful for the patient. 4 drops, go up to down, and as you have seen again, the powerful side of the needle facing the hot part of the kidney. That's essential. That's how you do it. And that I take control. Nice start with shrinkage with the type of the tumor. That's essential. After the control of this, we control them every 3 months. Don't do it before because the images are very difficult to see. At 3 months, I do only more dynamic hemorrhagic injection of gadolinium subtraction, so I can see better if there is a recurrence. Subtraction at this time. Now I'm not doing the control at 12 months if I can avoid it, if there is no complications. Another case, 55 years, RCC after partial leprectomy. That's again another recurrence here you can see. Here we have blood from the protection. Here, as you have seen, the tumor is in contact with the psoas muscles. Remember, there is the nerve of femoral nerve, which is not perhaps essential to the femoral nerve, but it's very sensitive. Those both nerves are good to the psoas muscles. Try to protect them. Try to protect them because then the patient will have trouble of sensitivity and they will tell you. That's why hydrodissection is essential to do. Here we are. The cavities are, junction is not far, this is junction. Again, we put an hydrodissection for the junction of the kidney, and that's done with the ice without damaging. Again, planning nicely before going to do it. Now we are going to a more aggressive cancer, recurrence post-surgery, partial nephrectomy, and the position of the recurrence is very bad, very central. And again, after the partial nephrectomy, here I have the junction. I have tried, we have tried to do one needle in the cavity to do a perfusion of the cavity because of the junction. One needle exactly in the center, in the junction, to inject fluid continuously. You can do the stent, but again, In this case, better to avoid doing the isotope junction. Then we put plenty of cryoprops. Have you seen it? It costs money, but for sure it's better. And again, same thing. Recurrence on the similar portion of the tumor, 75 on the wrong. Even if you have took all the precautions you have seen before, it's a central tumor, we have the recurrence. Means that could happen, and that's why you would need to be large. But again, because it's kidney, we have to be economized it. That could recur in the venous space. That's something you have to consider. As you can see here, small nodule biopsy recurrence in Iran. Aggressive tumor like tumor are easy to treat now, or again, very aggressive. That's why I was telling you, you need to exactly know what you are facing before doing it. It's essential to know the way. Another case that you have seen, central tumor like this. In those cases today, as I said before, what we are doing, we have to learn, because we have NGCT at the same room, we have the for DCT. We go and we put our props inside the tumor first, then the vascular access, radial, or femoral, we come and we put the balloon in the renal artery. If we can be selected better, but usually go to renal artery. And at the moment, we want to begin the freezing, we inflate the balloon. So like the surgeon will clamp the vessel during the 10 minutes of freezing. So we are completely shutting down the heating effect around the tumor. The success rate is a lot better, nearly 25% better than if you do it without. More aggressive, as I said, 10 minutes occlusion of the vessel is not really damaging the kidney, and it's cold. And that's what we do now systematically for central tumor. And that's a lot easier for us. In other case, top tumor, you are near the lung. Again, they could be difficult. That's why you know we are doing it. CT scan you can do it, what I'm showing you many MR because it's a lot easier, and majority of our tumors are done on MR projection. And again, MR guidance, as you can see, MR is real time. So avoiding the diaphragm is something easy because we can oblique upstairs without touching the diaphragm. A lot easier. But again, CT scan is perfect if you can see the tumor with ultrasound. No problem. Again, kidney, avoid nephrectomy, that's essential tumor again. That's what the choice. Nephrectomy or cryo, that's it. We have put plenty of cryo boxes. We have dissected junction. As you can see, it looks like this. All this at the same time, and then again, central tumor, you remember. Radial approach, small balloon in the artery. During the freezing time, the balloon is inflated. During thawing, the balloon is deflated. Again, the second phase, balloon inflated, in the large operations. That's it. That's very important to do it with this technique, and very rewarding because the results are a lot better. As you have seen, the major complications we got when you have it, in 3% of the cases in our series, Julian has published, there is hemorrhage in the first one, 3.2. This hemorrhage, if there is high risk patient, you are using flow-seal in the whole of ablation in this case. Flow-seal is expensive, it's a mix of prothrombin and gelatin. That's what the surgeons are using. It looks like reducing the bleeding, but I'm not doing it systematically because it's very expensive. That's one thing, and again, every time you have the problem of the patient be careful. Pneumothorax, less now because, as I said, doing more of the MR, you're very cautious, but again, hemorrhage is the first complication we get, and we should be very careful. But as you can see, the clinical results are getting better and better because we are taking the biopsy forward. That's what I was telling you. To make our paper valuable, we need to know what we are facing. As you can see, the results are always above 90% now. As I said, choose the right patients. That's important. Choose the right patients. Know exactly what you are facing. This histology, each grade, each station, what is around, which technique you are using, and put all your chances in your side. Central tumors, more probes, and eventually, if you can, balloon in the artery. Thank you very much for the attention.
After the session, we will go to the... Yes, you hear me, Dr. Afshin? We will respond to the discussion after the session, okay? Okay, we will go for the next session. Dr. Afshin will introduce our next speaker.
Thanks to the organising committee for the kind invitation. It's a real honour to be here and to be a part of this wonderful first ever radiological conference in Egypt. I'm going to talk a little bit about the role of nanoknife in the management of locally advanced pancreatic cancer. Okay, pancreatic cancer is the 10th commonest cancer in the UK, but it's also one of the deadliest cancers. It is one of the 5th commonest cause of cancer deaths in the UK. 80% of the pancreatic cancers are unresectable at presentation, and median survival for locally advanced pancreatic cancer is a mere 6 to 10 months. And this is particularly worse if the patients have got metastases. The median survival falls down to 3 to 6 months. The overall 5-year survival is also significantly poor. It's only 4%. This is because pancreatic cancer in general responds poorly to the available chemotherapy regimes. What is the need for local ablation in pancreatic cancer? Half of the deaths in pancreatic cancer are because of local progression. Local tumor control improves the survival, and local tumor control is also necessary for controlling the pain and local symptoms. Is ablative therapies for pancreatic cancer entirely new? No. There are a lot of ablative therapies which have been used in the past. Most of these were thermal ablative techniques, and none of them really gained any traction because of variable survival rates and also a significant amount of complications as well. The non-thermal technique, which is currently becoming popular in the last sort of 8 to 10 years, is the irreversible electroporation. So what is irreversible electroporation? Irreversible electroporation is a non-thermal ablative technique that takes advantage of the electric potential gradient existing across the cell membrane. If you subject a cell to high voltage electricity, you can cause irreversible damage to the cell wall, resulting in the collapse of the cell death, and apoptosis. There's no temperature involved. So it is called nanoknife because it produces nanopores within the cell membranes, which in turn causes macromolecules to move in and out of the cell, causing cell death. That's why it's called nanoknife. Is it an entirely new technique? No, it isn't. It is something which has been used in the past for treating certain types of chemoresistant tumors. If I can point out, yeah. So if you look at the middle picture here, this is a reversible electroporation. This is a technique which has been used in the past where you apply lower power electricity for a shorter period of time to create temporary holes in the cell membrane so that the chemotherapy can enter the cell. So certain types of sarcomas, cutaneous sarcomas have been used in this past. Now, irreversible electroporation is an advancement of this technique where you apply higher voltage electricity for a longer period of time and you create permanent cell destruction. So what are the advantages of IRE? IRE produces a sharply demarcated area. It spares the connective tissue architecture, so that means that there is sparing of the vessels and the ducts. And also IRE relies on electrical energy and not thermal energy, so therefore there is no heat sink involved. The disadvantage with IRE is needle placement is absolutely critical. You need to place the needles not more than 2 centimeters apart, and also the needles have to be as parallel as possible to create this cylindrical zone of ablation. I'll demonstrate this in the next slide. So for example, if you have a 2 centimeter tumor, it is very important that you bracket the tumor with at least 4 needles, okay, like this. And the needles have to be as parallel as possible and should not be more than 2 centimeters apart, because in that way you can create this symmetrical electroporation zone, which means the needles will start pulsing electricity between each needle set and create this ablation zone, which completely encompasses the tumor. So if you cause if there is any slight discrepancy between the distance between the needles, then you can cause an asymmetrical electric field, and that can affect the integrity of the ablation zone, and meaning that there is a higher chance for recurrence or incomplete treatment. The equipment itself is pretty simple actually. It comes as a form of a generator, which is the size of an ultrasound machine, and it is in this generator you can plug in 4 electrodes at the front. Okay, and because you're using high voltage electricity in the liver or in the pancreas, which are very close to the heart, you can cause cardiac disturbances. That is why it is important you synchronize the electric pulse delivery with the ECG so that you do not cause any cardiac rhythm disturbance. Okay, so that's why it comes with an ECG synchronizer as well. Where is IRE used for pancreatic tumors? IRE used for adenocarcinomas when they're inoperable, as a palliative procedure for controlling the local tumor progression and prolong the survival. It's also used for borderline operable pancreatic cancers as a means of margin accentuation to get those negative resection margins and therefore prolong survival. And it also can be used in neuroendocrine tumors as a primary therapy, particularly for small neuroendocrine tumors. You can avoid a major operation. The tumor size is very important. Evidence so far suggests that if you treat tumors less than 4 centimeters, you will get the best possible local results. And this is a technique that can be done percutaneously under CT guidance or ultrasound guidance as well. And if you're doing it intraoperatively, you obviously would need a good ultrasound guided technique. There are certain contraindications for IRE. Patients with pacemaker and patients with cardiac arrhythmias are not suitable, particularly because if the patient is dependent on the pacemaker and you're applying high voltage electricity, you can affect the functioning of the pacemaker. So it has to be made sure that the patient is not dependent on the pacemaker. If at all, you have to do a patient who has got a pacemaker. Metal stents in the area, in the treatment zone, can cause disturbance in the electric rhythms. So it may impact on the integrity of the electric field, and therefore the efficacy of the tumor. So any metal in the treated zone could cause problems in terms of delivery of the electric field and creating the electric field strength. This is one example of a small neuroendocrine tumor within the head of pancreas. It can be seen nicely on ultrasound, and this is the tumor sitting next to the SMV there, just as a small hypervascular tumor. And this is something which can be easily treated with a percutaneous technique. Just 2 needles are enough because it's such a small tumor placed on either side of the tumor. And this is the CT scan immediately after the procedure. You can see that there's a lot of edema in the treated zone. You can see the superior mesenteric vein, because of the edema, is compressed and it's quite small. But if you repeat a CT, and exactly a couple of weeks later, all the edema would go, and you can see the SMV is normal in size now, and more importantly, the tumor is no longer present. It's no longer hypervascular. And this is the follow-up scan 18 months after the treatment, showing no recurrence within the treated zone. This is an example of a locally advanced pancreatic cancer. Here you can see a large tumor in the head of the pancreas, completely encasing and also stricturing the superior mesenteric vein. The tumor is also abutting the superior mesenteric artery as well. So this is a T4 cancer. This is a patient who completed chemotherapy, but the tumor did not respond, did not shrink in size sufficiently enough to go for operation. So what else can you offer? You can offer NanoKnife for this patient to control the local tumor progression. So this is what we did. So we placed 4 needles inside the tumor, and this is the CT immediately after the treatment, showing a lot of edema within the treated zone. And this is a CT 6 months after the treatment, showing a reduction in the vascularity and also a reduction in the tumor bulk. So there is some good local control that can be achieved. And if you achieve good local control, then potentially you can prolong the survival in this group of patients. There are some complications with NanoKnife as well. Pain can often be a problem because edema initially can cause a lot of pain in the epigastrium afterwards. So you can mitigate the pain by giving some steroids and reduce the amount of post-procedural edema that can reduce the pain. Pancreatitis was also a problem. Majority of the patients get low-grade pancreatitis, which can be managed simply with painkillers and analgesia for a period of time, and they usually get better. Rest of the complications, the significant complications like bleeding, bile leak, and bile stricture are uncommon, but again, this is something you need to anticipate. This is an example of a patient with a pancreatic head cancer, completed chemotherapy, it remained inoperable because the tumor was tracking along the gastroduodenal artery and encasing the hepatic artery. So the patient came for a nanoknife procedure, and again, he had needles placed inside the tumor, and this is the immediate follow-up CT scan showing tumor necrosis. But 1 week after the treatment, the patient presented with a GI bleed, gastrointestinal bleed, and the CT performed at that time showed a large aneurysm of the gastroduodenal artery. This was promptly treated with embolization, and the patient survived, and he did well after the procedure. This is a follow-up scan 6 months after the treatment showing a reduction in the bulk of the tumor, saying that basically there is a good local control. So this is something which we need to watch out for, particularly if you're treating tumors that are completely encasing the arteries. What that means is you're not only treating the tumor, you're also treating the vessel wall, which is actually replaced by the tumor. So pseudoaneurysms are something that you have to anticipate and you have to manage. This is an example of a patient with a small neuroendocrine tumor sitting next to in the head of the pancreas, but sitting very close to the distal bile duct. So if you treat this area, obviously you're going to create a lot of edema, you create a lot of inflammation, and you can produce a bile duct stricture. This is what happened in this patient. He had developed a bile duct stricture, and he started leaking bile from the cholecystectomy stump. So he was managed with ERCP. You can see the low bile duct stricture there, and he was treated effectively with a stent. The stent was kept in place for 3 months, and afterwards the stent was removed, and he made a full recovery. So looking at the literature, this is probably the largest series which was published by the Rob Martin's group in the States, where they looked at 200 patients at multiple centers treated with nanoknife for locally advanced pancreatic cancer. And you can see out of these 200 patients, 50 patients had had IRE followed by Whipple's resection, whereas remaining 150 patients just had nanoknife and did not follow with an operation. Almost all of these patients had chemotherapy, and about 50% of the patients in each group had chemotherapy as well as radiotherapy as well. And if you look at the survival figures in these group of patients, the median survival in all patients was 24.9 months, whereas patients with IRE and Whipple's did much better. Their survival was 28.3 months. And patients who had IRE alone was 23.2 months, the median survival. If you compare with our historical figures, the median survival for patients with locally advanced pancreatic cancer is between 6 to 9 months. So there is definitely a survival benefit with IRE in patients with locally advanced pancreatic cancer. This is a European meta-analysis looking at 10 studies. Again, patients treated with IRE. There are 446 patients in total. 140 of them had percutaneous IRE under CT guidance. The remaining 300 patients had intraoperative IRE. The mean tumor size was between 2.8 and 4.5 centimeters. They reported a technical success between 85 and 100%. Complications were 35%. Majority of them were minor complications, and 9 patients died within 30 days after the procedure, so their mortality was 2%. The median overall survival in this group was between 7 and 23 months, which is again similar to what has been reported in the Rob Martin's group. And the longest survival was seen in patients who had IRE followed by Whipple's. Another role of IRE is a technique for margin accentuation for borderline resectable pancreatic cancers. We get 2 types of cancers. The borderline resectable are those ones where there is less than 50% encasement of the SMV and the artery is generally not involved. In these group of patients, once they've finished a trial chemotherapy, they can proceed to have a Whipple's procedure, but with margin accentuation, which reduces the margin positivity. So why is it important? Because majority of the patients who undergo Whipple's resection for resectable pancreatic cancers develop margin positivity on histology. So margin positivity on histology is directly related to survival. And these patients do poorly if they have positive margins on histology after survival. So the presence of R0 resection is very important. That predicts the survival in this group of patients. So what do we do? So we need to make sure that all of these borderline resectable patients should have chemotherapy first of all, to downstage if possible. then mobilize the pancreas as for Whipple's, then identify the margins first and treat the margins with IRE, then followed by pancreatic transection and PV resection as well. So this is one example of a patient with a borderline resectable tumor. You can see the tumor is encasing the SMV, but generally the artery is preserved. And this is after the chemotherapy with FOLFIRINOX, which showed a significant reduction in the volume of the tumor. The tumor is now well away from the vessels as well. And what we did was we identified the potential resection margins using intraoperative ultrasound, and then we treat those margins. So first we treat the pancreatic neck by placing 2 probes on either side of the pancreatic duct, as you can see that here. And then next we treat the SMV groove. That's the other place where you tend to get positive margins. So you place 2 needles on either side of the SMV within the SMV groove on the posterior aspect of the pancreatic neck. And lastly, we treat the posterior margin by putting needles in the transduodenal plane and treat the posterior margin. So this is the histology afterwards, and you can see this is the transection plane, and you can see the nicely cauterized treated zone without any positive tumor at the site where the tumor has been transected. And you can also see on histology that there is a lot of tumor necrosis and there is no viable tumor in and around the resected zone. So this is our pilot study which we published last year, looking at the margin accentuation as a trial for resectable pancreatic cancers. The idea was to see the margin positivity using IRE for resectable pancreatic cancer and to see the disease-free survival and compare that with the retrospective cohort we have in our institution. So we selected 20 patients. All of these patients underwent margin accentuation with intraoperative IRE in the operating room prior to having a pancreatic duodenectomy. We treated 3 margins: the pancreatic neck margin, the SMV margin, and the posterior margin with intraoperative IRE using ultrasound guidance. And these are our results. In the IRE group, the overall margin positivity was 35%. In the non-IRE group, it's significantly higher at 51.6%. The complication rate there was no significant difference in the complication rate in either group. And if you look at the overall survival, the 1-year overall survival in the IRE group was 94% and the non-IRE group was 92%. There's not much difference there, but if you look at the 3-year survival, there's a significant difference in the IRE group compared to the non-IRE group. The IRE group had a 3-year survival of 90%, whereas the non-IRE group had a significantly lower survival of 60%. So it's a very important thing. So what I suggest, so our conclusions are, allowing for the small sample size we used and a small follow-up period, there is a statistically significant reduction in the margin positivity in the patients who had IRE at the time of Whipple's procedure, and also significantly better midterm survival in patients with resectable pancreatic cancer who underwent margin accentuation with IRE. So where do we go from here? I mean, there's a lot of research being done about how IRE acts as an immune modulator. So IRE is something which can sort of not only cause tumor cell apoptosis, but it can enhance the immune profile in the tumor. So if you combine IRE with immune mediators, particularly like checkpoint inhibitors, you tend to get much better results. So this is something which is being researched on as we go by. So we will have more results in the years to come by. There's also studies going ahead which says that IRE makes tumors more susceptible for chemotherapy. And again, we'll get the results of that in the next couple of years' time. And hopefully those will also increase the usage of IRE in pancreatic cancers as well. So to summarize, what I'd like to say is thermal epidator techniques are associated with high risk of complications. IRE is safe and feasible with good short-term outcomes. But the IRE is also a complex technique that demands a steep learning curve. It's something which people have to master, get used to the technology, and do a lot of procedures before they can get comfortable with that. Future developments, IRE plus chemotherapy and IRE plus immunotherapy, are looking very promising in terms of offering better results and poorer and lesser chance of lesser recurrence rates. But we do still need more controlled studies to evaluate the long-term prognosis. Thank you very much for your attention.
Thanks so much, Prof. Preveen.